Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, we will be learning about the steps advanced practice providers can take to increase the frequency at which PrEP is offered in primary care settings, including available training resources, accessible PrEP options, how to use electronic health records to identify candidates for PrEP, when to discuss PrEP with patients, and how to simplify PrEP for both patients and providers. I'm joined by Dr. Tavell Kindall, a nurse practitioner and director of HIV prevention and treatment at the St. Thomas Community Health Center in New Orleans, Louisiana, and Jona, a physician associate and medical program lead for substance use disorders at Whitman Walker Health in Washington, D.C. To find more information about our expert faculty, as well as other activities from this program, including downloadable slides, please visit the links in the show notes for this episode. Now let's get started with Tavell Kindall.
So Jona, I'm so excited to have an opportunity to have a conversation with you about PrEP in primary care. Certainly we know that we are going to need our primary care colleagues to help us in the HIV epidemic through our prevention efforts. And so when having conversations surrounding PrEP in primary care, oftentimes primary care providers may be a little bit anxious about doing PrEP and want some guidance on how to do it. So I'm hopeful that this podcast that we're doing is going to be helpful in terms of removing any fear that primary care providers may have regarding PrEP.
Absolutely. I really think that PrEP is something that APPs can not just do, but also excel at. I think that there's a lot of fear sometimes in the community that maybe it needs to be something that comes from an infectious disease provider or someone who has a larger background. But I think APPs is one of the larger segments of primary care, and people who more and more are who people receive their primary care from are uniquely positioned to really offer PrEP and get it to more people and try to address some of those gaps. So I'm really excited to speak with you today as well. We can go over some different steps that we think that APP specifically can use to offer primary PrEP and primary care.
Absolutely. So, one of the first things that APPs need to do is get trained. So there are a number of resources that are out there. I know for nurse practitioners, I'm a nurse practitioner, and so I can speak to some of the resources that are available through the American Association of Nurse Practitioners on their website, and just among colleagues that are members of AANP that do HIV prevention work. I mean, certainly the collegial opportunities are there for those providers. The American Academy of PAs also have resources, and I know you can speak to that a little bit more as well as a PA.
Yeah, absolutely. I think they do a great job of offering like a big suite of CME. And I know that the yearly conferences always contain content on PrEP and in general also care for sexual and gender diverse people. So there's a bunch of different resources there. But if you're looking for resources without a paywall, which I know that a lot of people want CME without a paywall, there are, of course, many out there, including where we're speaking right now, Clinical Care Options. But certainly, I think starting with your national organizations, even if you just want to also look for other people to route you to resources, I think that's a great idea. Another step also that people can take that I think is really important in terms of getting your hands dirty in terms of prescribing PrEP is learning how patients can access affordable PrEP. Now, TDF-FTC is probably the most affordable one, but if we're looking at some of the other branded drugs, there are patient assistance programs offered by the drug companies that can really take a burden off.
Absolutely. Now, I happen to work in a state where Medicaid covers the cost of all of the options for HIV prevention. So my Medicaid population, we're not having to do a lot of heavy lifting in terms of access for prevention medication for them. Any of the options, TDF-FTC, generic, and even the branded products, and even the cabotegravir for long-acting injection, which is really exciting. However, for those individuals who have commercial insurance, to your point, there are those patient assistance programs that are offered through the drug companies that can be very, very helpful. And then just kind of having your bearings around what information is most important for prior authorization, if you need to go there in terms of, getting patients access to PrEP.
Absolutely. And then practices where it's okay, a lot of these drug companies will also offer samples, which can be really great for the uninsured, but also for getting people on same day PrEP starts. So if their insurance is going to take some time to sort of get things straightened out, offering a sample packet can be a way to give them a 1 month supply to give you time for those authorizations. Another great step to offering it to more people is including it in electronic health record templates.
Yeah, absolutely. Having opportunities to identify those individuals who can most benefit from PrEP and using that technology in your EHR is going to definitely be beneficial. So building those templates in your EHR if possible, removing any restrictive issues to where that you miss opportunities, you definitely want to do that. And then just have your templates to be where they are general in that you have an opportunity to address all individuals who just perhaps are sexually active, and even think about ways to incorporate the status neutral approach to HIV prevention and screening and taking advantage of those opportunities. The literature now is guiding us towards not just stopping when the HIV test is negative, like take the next step and take advantage of building those kinds of things into your EHR, having the conversations about, okay, so now that we know that your HIV test is negative, then what does that mean? How do we keep you negative? And do you know about PrEP? And if so, in terms of your history and the information that's provided, are you someone who could truly benefit from that? So that way the EHR kind of guides you and you don't miss the opportunity.
Absolutely. And, I think something else people can do if there is that ability in certain EMRs is data pulls on the back end, looking for anyone who's had a diagnosis of an STI or something else like that, really trying to make the most out of your electronic medical record system. Or if you're in a place, perhaps like myself, where you have an older EHR that doesn't do these things, using this as another example why you need a better EMR. I'm always looking for another reason to try to convince people to upgrade and invest in digital infrastructure.
Absolutely. So again, take advantage of those critical opportunities, like for someone accessing care for birth control or accessing care for sexually transmitted infections. Either they believe that they have one, they have symptoms, or perhaps, you have diagnosed them and you're having them to come back to address it. Those are perfect opportunities. And any sexual health complaint, this could be someone who perhaps is older and maybe there have been some changes in terms of their sexual abilities, or perhaps changes with sexual pleasure for our older individuals. And so we want to take advantage of those opportunities as well, because some of the things that they may be doing to have more pleasurable sexual experiences may be placing them at risk for HIV.
Yeah, definitely. And I think something you said that's really struck me is also thinking about our older adults and presentations about sexual pleasure. People coming in to ask about drugs like sildenafil or tadalafil, et cetera. Those are all really great opportunities. And also, people looking at the data, oftentimes people will become unpartnered as they become older adults, and they may be seeking new partners. And so really also making sure that one of the ways you could not miss those opportunities is making sure that you're asking a good sexual history from everyone also, so you can identify those opportunities and you're not missing people who you may not necessarily think of as going to be sexually active, but are and need sexual health care, including PrEP.
Absolutely. So now a very critical step is making sure that you are appropriately screening for STIs in all the places where people have sexual practices. So 3-site testing. And when we talk about 3-site testing, we're talking about extragenital screening. So that's the screening of the throat as well as the rectum for anyone who may be participating in receptive anal intercourse. But it's important for you to find out how to do that at your facility. You may have a contracted laboratory company at your clinic, like I do, to where my nursing staff does the extragenital collection and the samples are sent away for testing. However, if you have someone who you send to one of the patient service centers in the community for STI testing, they may not collect those oral and rectal samples. And so you miss those opportunities. So it's important for you to kind of be thinking about that and thinking about more creative ways to make that happen if you can't get those collected at your site.
Absolutely. And, I think something that's difficult is that there's not really any specimen collection at your particular clinic. Oftentimes it seems like it's too much of a big barrier to overcome. Because if you just do lab orders, large companies like Quest, LabCorp, and many of the other large lab conglomerates, they won't do the swabs. However, something you can do at your practice to make this easier so it's not a burden for you and it actually gets done, because the large lab companies often will not do it, is to offer self-collection or self-swabbing. Now, this is evidence-based. Many clinics do it, including the clinic that I practice at. It's a real, oftentimes patients prefer self-swabbing, and the research out there shows that they're just as good as swabbing their own throats and rectums as we are, and it can really take out that awkwardness. So it really is the standard of care, and you can get creative so that way it doesn't become more work for you or your facility, just offering those self-collect swabs and then having a company like Quest, LabCorp, or some other lab conglomerate pick up those swabs from your particular clinic and starting that sort of program.
Absolutely, absolutely. Now, you may work in a solo practice, but you also may work with colleagues. And if you're working with colleagues, it's important to try to get everyone on board in terms of who is offering PrEP, and not just one person getting all of the referrals for PrEP. I mean, that could be very overwhelming for one provider, and it's a barrier to access.
Absolutely. And patients oftentimes have great relationships with their PCP. They'll trust their PCP. And if their PCP recommends PrEP to them, they're much more likely to participate. And having that one additional appointment, whether that be with just another person in your practice or an outside provider, that can be a huge barrier for people when it could be something that's done easily in a visit. And honestly, PrEP visits are pretty easy to offer by themselves, but they're also easy to tack on to other regular primary care or chronic disease management visits. It's really just checking in that they have enough of their medication, making sure that they're doing their labs, and also assessing for adherence. Is something that can be quick and easy, so that way it doesn't become something that, as Tavell said, is really a burden on one person in your practice. I think the other thing too is that really separating it out to one person in the practice can almost sort of increase the stigma, because patients will start to wonder, why is my PCP not offering this? Why are they sending me to someone else? And so as much as possible, making sure that everyone understands that it's easy and that they can do it, I think that's really the best practice.
Absolutely. Wrapping PrEP into primary care for other management of other chronic conditions or management of other conditions and health considerations is one significant way to reduce stigma surrounding HIV prevention and PrEP, and also helping you to reach those goals in terms of what you're trying to get accomplished for those other conditions. So definitely take advantage of those opportunities as well. PrEP in primary care can be a win-win for a number of ways.
I think for some people, the logistical barriers can be somewhat daunting when it comes to offering PrEP, although oftentimes once you start to do it, you'll find that they're easier than you thought. But this is a really great opportunity to investigate how you can get support from support staff and employ different kinds of people on the healthcare team to assist with really building out a robust PrEP care clinic at your particular location. So this could be things like employing navigators or care coordinators to assist with scheduling those every 3 months visits, or every 2-month visits for people on injectable PrEP can be daunting, especially for provider, or if your front desk staff perhaps are less trained, or perhaps your system doesn't automatically remind people. But employing other health professionals or bringing them into the team to assist with that care coordination can be really helpful.
Absolutely. Where I currently work, we have evolved our role from PrEP navigation to HIV prevention coordination. And so these individuals are not just in the agency and available to our providers, but they are also out in the community as well, establishing relationships and helping communities to be knowledgeable of the opportunities that are available for HIV prevention, and making sure that they're educating individuals about HIV incidence and prevalence in our community. I'm focused more than ever, on women of color and their risks for HIV acquisition. And so I have an HIV prevention coordinator that I have recently employed, who is a cisgender Black female, who she will be hopefully more impactful in helping us to increase PrEP uptake among Black women in our community.
Absolutely. And I think one other part where support staff can be really helpful is with prior authorizations. If you have admins on your team, training them how to help with the prior authorizations for PrEP, whether that be long-acting cabotegravir or TAP-FTC, very rarely will you see a prior authorization nowadays because of the USPSTF rating for the generic TDF FTC. But even so, everywhere in the country is different. But as much as possible, coordinating with them directly to try and simplify the prior authorization process. I know at our particular practice, we actually have a little template for PrEP prior authorizations for the long-acting cabotegravir as well as for TAF FGC. And, the admins that we employ are familiar with this template, and it really makes things easier, makes it much less of a worry. You really know whether there's going to be coverage or not. You don't have to be guessing, and the patient doesn't have to be waiting around for an answer. But I really loved hearing about that idea of having a navigator specifically of the community of cisgender women of color. I really think that's so needed.
So another thing that can be very helpful in terms of the process of identifying someone would be making sure that your staff is trained on rapid testing, because that can be a quick way to confirm that someone is HIV negative, and then that way they can move on forward and get access to their PrEP. And then also the ability to do more community activities is increased when you're able to do rapid testing.
Absolutely. And, I think as much as possible using mobile testing to get to the community, especially for those that are practicing in urban areas, thinking about getting mobile testing to different sex venues like gay saunas, etc., or just in general, any venues that might be sort of associated with sexual cultures can be really a great way to get people into PrEP care, get into practice. But, also the new CDC guidelines, which are really simplified for offering PrEP, do include the option of using the rapid testing as part of the PrEP follow-ups. But, it can also just be a way to simplify those routine PrEP visits, or maybe even offer at-home testing for patients if they don't necessarily always want to come in. Options perhaps give them a rapid testing kit or send them a rapid testing kit if you're able to do that, especially if you work with a clinic that maybe offers a little bit more flexibility or has some more options. That can be a really great way to get those PrEP follow-ups done. Another step that we can move on to in terms of trying to get it, make it more convenient for patients rather than just mobile testing, is thinking about how you can offer Tele-PrEP or use telemedicine to really expand PrEP access. A lot of practices nowadays in the post-pandemic world are already offering telemedicines in different forms. And these are really easy visits. They just involve labs and, like I said, a few questions just to assess how the PrEP is working for that person. So telemedicine can be a really great way to get PrEP to more people. There's a reason why these large Tele-PrEP companies exist to offer people PrEP. And so for those with insurance, oftentimes because those big Tele-PrEP companies don't take insurance, if you're already seeing these patients, you can use telemedicine to offer that same convenience.
Absolutely. And where I currently work, we're looking at implementing a Tele-PrEP program specifically for that reason. It's just so much more convenient for people to access PrEP. So they can log on, have a conversation with their provider, go and get their labs done, and the provider can send their prescription once they're confirmed to be HIV negative. And then it kind of removes them having to go to see the provider. This is an opportunity for them to kind of feel as though that they are empowered and they are in charge of their health by doing it a way that doesn't require them to be physically present in the clinic.
Absolutely. And, it can even be just a way of thinking about it for those people who are practicing in clinics where there's productivity or incentive-based payment models. This is really easy productivity. These visits are short, they're simple, you can really stack a bunch of them. You'd be surprised how fast a day of just Tele-PrEP visits just flies by. They're fun visits oftentimes too. So if you're in those incentive-based models, I wouldn't write off Tele-PrEP or PrEP in general. It can be a really great way to boost some of your productivity, get more appointments on your books, while offering a really important service to patients.
Indeed, indeed. So one thing to really think about is, I know we've mentioned just several things about barriers, but it's important for you to not let any of the barriers get in the way. But think about what are your biases about PrEP. I think that's a very, very important thing to think about, and offering PrEP and making sure that you're not placing your beliefs onto people who are coming in needing PrEP and accessing PrEP, or identifying those individuals who could truly benefit from it.
Yeah, absolutely. I really like what you said sort of about the moral obligation as providers and doing no harm and beneficence to really offer PrEP to all people. It's an important part of care, and it's really not specialty care. What I'd also highlight, and what I love about this specific series for advanced practice providers, is that this is absolutely within the scope of practice of advanced practice providers. This is not reaching above our license at all. In fact, I'd say this is far below the ceiling of what is the maximum we can practice for. So I think owning this, really showing that APPs are uniquely positioned as primary care providers, as people that oftentimes patients feel like they have better access to, that they have better relationships to. It's so important to offer this care. And it's definitely something like exactly like Tavell said, it seems like we just talked about some barriers. These are very surmountable barriers. And, baby steps, changes incremental. I think if you just take it one step at a time, sort of have a patient that is willing and interested and will help you work out sort of those different kinks in terms of the logistics of offering it, I think you'd be surprised about how simple and rewarding it is. It's really wonderful in medicine where you have something where you can do something, you can offer something to people that is just wonderful for them. It's a great preventative measure and that they're excited about, and that where people really feel seen and affirmed. And I think really giving people all the tools for sexual health can be a really great way to do that. We're living in a world where HIV prevention, where in terms of safer sex in general, isn't just condoms anymore. There are a lot of people out there that don't necessarily want to use condoms. There are a lot of cisgender women with IUDs that are not interested in using condoms. There are plenty of queer people all under the spectrum who are on PrEP or on HIV treatment, don't want to use condoms with their partners, etc. So making sure we're taking that status neutral approach, we're overcoming those barriers and making sure that people are really familiar with all the tools they have in terms of sexual health, rather than just condoms, I think can really be so beneficial for our patients.
Absolutely. I have nothing else to offer in that space. You nailed it.
Thank you. I appreciate that. One of the last things I'd love to just touch on, and I think that we can have a conversation about as people who do this more often, is sort of the nitty gritty that I think also it never gets taught in schools, is something that people don't like to talk about, is that billing and coding, which can be scary for some or feel like it's labor. What's really wonderful is actually there's a new ICD-10 code specifically released to be used as the primary code for these visits now. And some, especially the more up-to-date or modern EMRs, already have it employed. It's ICD-10 code Z29.81, Encounter for HIV Pre-Exposure Prophylaxis. So especially for those of you in private practice working with a lot of commercially insured patients, if you're worried about PrEP visits accidentally being billed to them because you're using an EMN code, but really it's preventative because usually you want to use an EMM code. If you set this as your primary diagnosis code, the reason why it was created is to really signal to those private insurers that this is actually, even though it's being E&M coded, it is a preventative visit. And so by doing that, it makes the visit a lot easier. You can avoid a lot of the headache associated with billing, especially for patients when it comes to these visits. And then just using your good old routine screening for STI. And for those that when you do the creatinines for people on oral PrEP, using that other long-term current drug therapy. I specifically like that code because I find that patients don't like to see high-risk medication use, which is the same Z code, but a different sort of words after it, a diagnosis, just because that can lead to some stigma, when they think, oh, I didn't realize PrEP was a high-risk medication. So simple coding, all you really have to know is 3 diagnosis codes, one for the STI test, one for the primary code, and you have that beautiful code right there, and then one just to get those creatinines covered for people on oral PrEP.
Yeah, absolutely. And it's important to avoid stigmatizing codes. I know you're kind of starting out, there were codes that were being used like high-risk homosexual behavior or high-risk sexual or bisexual behavior. Those codes, we really should avoid using those codes. Those codes can be stigmatizing.
Absolutely. And in terms of the E&M code, I'm a huge fan of time coding. I think it just makes things easier. Me personally, for all my PrEP visits, I just use a good old 9213, greater than 20 minutes spent. And that just makes things so simple, especially with those newer diagnosis codes.
Absolutely. Well, I think that's all the time that we have. I'm hopeful that the information that we've shared will help advanced practice providers in primary care feel more comfortable in offering PrEP. Again, don't get overwhelmed. It's easier than you think, and it's definitely beneficial for our communities, particularly those communities in which we know that HIV incidence is high.
Yeah, and thanks for speaking with me. This was great. I learned so much from you, Tavell. I hope that people also in the audience learned some things to take away today. If you take away anything, it's just that PrEP is easy. We should be offering it. And, as APPs, we can be APP proud and really own this particular type of care.
Great. Have a good one.
Thank you very much to our faculty, and thank you to our listeners for joining in. As a reminder, to view the full program, Paths Forward in PrEP, Overcoming Barriers to PrEP Engagement in Principal Populations, on the Clinical Care Options website. And to access more activities on this topic, click on the links in the show notes for this episode. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.